Hi, this is Dr. Bob Dannenhoffer. I'm the Public Health Officer of Douglas County, doing our COVID conversations and more today on March 31st, 2022. I'm joined today by Laura Turpen, who is one of the epidemiologists, actually our chief epidemiologist for the county. And we'll talk a little bit more about hepatitis B, which is one of the incredible successes of public health in my lifetime. But as always, we'll start off with questions. And if you have questions, please send them to us at Facebook questions at douglaspublichealthnetwork.org. So Facebook questions at douglaspublichealthnetwork.org, and we'll get those and answer those the next time. But as we always do, we start at the ward level and then move down. At the ward level, COVID is pretty quiet. There was certainly a big Omicron peak and a slight peak of this BA2. But that's also seeming to quiet down too. There's still a fair amount of disease in Asia. So South Korea, Japan, and China are struggling a bit now with cases. But because they have high levels of immunization, they're not seeing lots of deaths. Africa is pretty quiet, except we're seeing a real spike in Botswana. And what we've seen is when there's a spike in one country in Africa, it spreads outward. Europe is about stable, but North America and South America are seeing a decreased number of cases. The big issue in the places is this BA2 variant. So the BA2 and the BA1 variant, which we called Omicron, are very similar, but they didn't come one from each other. They probably evolved at the same time. They cause a milder kind of disease. Still not totally mild because there's still people get it sick and get hospitalized and die, but a milder form of disease. Both are well controlled by the vaccine. Both are well controlled by Paxlovid and molnupiravir, which are those oral antiviral meds. Sotrovimab, which is the injectable one, does not work as well against the BA2. We're seeing in many places, all they have is BA2. So in England, Denmark, China, pretty much it's all BA2. In the US, we're about half and half BA1, BA2. Oregon, we're still mostly BA1, but I think it's only a matter of time until we get to more BA2. In the US, the number of cases going down, but I am seeing an increase in cases in places that had an early BA1 spike. So Washington, D.C., New York, Puerto Rico had early BA1 spikes in December. And now here at the end of March, they're having a little spike, not nearly as big as they had before, but a little spike of the BA2. So when I look at what happened in England, where they had a big Omicron spike and then a slight BA2 spike, New York, Washington, and Puerto Rico, I would have to think that that's probably going to happen in Oregon at some point, but probably not for another 6 or 8 weeks. So probably not before the end of April, but maybe in May or June, we would see another little spike from the BA2. The predictors, the people at Oregon Health Sciences University who make those predictions also think that we're going to see a small spike in hospitalizations in May. In Douglas County, we're having an incredibly low number of cases. I looked at the report this morning. We had just a single case in the last day. And Tuesdays, Wednesdays, and Thursdays tend to be our high report days because there's some places not reporting on the weekends. So we tend to see our highest counts on Tuesday, Wednesday, and Thursday. And we had just but a single case today. So the number of cases in Douglas County is way down, and the number of hospitalizations is way down. But the BA2, we think, is probably going to be coming. And I wouldn't be shocked if at the end of April or in May, we would see another little spike. But again, a few good news. One is the vaccine seems to work. When we've looked at our last deaths, almost all of those people are people who are not up to date on their vaccines. So again, please get vaccinated. The other new news with vaccines is we know that for old people like me, that the booster starts to lose its effectiveness after a few months. And so now there's a recommendation that for people who are 50 and above, me, and for people who have weakened immune systems, that they would get a second booster a few months after their first booster. So I'm going to be getting my booster next week, my second booster next week. And I'd recommend that people 50 and above or those with immune conditions also go ahead and get that. The second big news this week is that the oral antiviral drugs, the Paxlovid and the molnupiravir, are here in town. They're generally available, so that if you do get COVID, they should be available to anybody who is high risk. And that would be people with underlying conditions or older people, that they would be available to get these meds. They're not perfect. They don't work 100% of the time, but there's almost no medicine that we have that's perfect. So if you have an ear infection, I treat you with an oral antibiotic. maybe 70 or 80% effective. If you have pneumonia, we treat you with an oral antibiotic, maybe 80 or 90% effective, but nothing's 100% effective. But Paxlovid is about 90% effective, so really quite effective at preventing hospitalizations and death. Molnupiravir a little bit less effective, but still certainly worth using. Both of these medicines are oral medicines that you would take twice a day for 5 days. They have relatively few side effects. So we're really recommending that people who do get COVID, and again, not very many people getting it now, if you're at high risk, talk to your doctor about getting one of the oral antiviral meds. The other news that's out there this week is that the sotrovimab, which is this injectable medicine. You remember back last summer, we used Regeneron, which was an injectable medicine which worked well against Delta. Well, worked well against Delta, but did not work against Omicron. So sotrovimab did work well against Omicron, but does not work against BA2. But there's a new one out with an unpronounceable name that does work against BA2. So if you're unlucky enough to get it, you have two options. You can use the oral meds, the Paxlovid or the Molnupiravir, or at the hospital, go ahead and use this new injectable medicine. Our goal at this point should be very few cases. And if you do get it, very few hospitalizations and very few deaths. Once we get to that stage, we'll be kind of past COVID. And then we can go ahead and work on some of the other stuff that we're going to be working on. And we'll talk with Laura about that in just a minute. One of the questions we got this week is, what about ivermectin? Well, you can't go a week without talking about ivermectin. And so I think 2 new studies are in with ivermectin, and both of them showed that really didn't help. These were done in people who already had the disease, and one large study done in Brazil showed it really didn't help. So again, I think we can kind of put ivermectin to bed, but now that we have really much more effective medicines, Molnupiravir or Paxlovid, that's really the way to go, I think, if you would get it. So that's where we are with COVID. We're hoping to put this in the rearview mirror, although I think we're still going to see a little bit of drama when BA2 comes. And if there's a new variant, we could see something there. But when it's quiet now, we focus on some of the other things that we do in public health. And I'm joined today by Laura Turpen, who's the chief epidemiologist at DPHN and for the county. And one of the many jobs she's had, it's amazing how many things she does. But one of the things she does is she helps us with perinatal hepatitis B. And that is a goal that we have in public health, to rid our society of hepatitis B. So I'll go back to this 1980 when I graduated medical school. Hepatitis B was a very common infection. Hepatitis B is transmitted by even a tiny amount of blood. So by a needle stick, even just doing an oral exam on someone, you could pick up hepatitis B. It spread very quickly in families, so that if one person in the family had hepatitis B, it was pretty much sure that everybody in the family would get it, just because the families are so close and they share so much. And hepatitis B is bad. Most people got an acute infection. They were pretty sick. They missed a week or 2 of work, got really jaundiced, really sick to their stomach. And then most people would recover, but a considerable number of those people who got hepatitis B would then have chronic hepatitis B. And that chronic hepatitis B led to all kinds of problems. It led to liver cancers, and it was one of the leading causes of liver cancer back then. And if you were pregnant and had this chronic hepatitis B, you were very, very likely to pass it on to your kids. And so I, as a pediatrician, would sometimes see older kids have it, but I'd see lots of babies who were born to hepatitis B positive mothers. And almost inevitably, those babies would get hepatitis B. And I can remember one of our saddest cases of a 6-year-old who came in who'd had hepatitis B as a baby. And when we saw them at 6 months, had incurable liver cancer and died. The other problem is that many of these babies who picked up hepatitis B at birth would carry it their whole lives and then pass it on to their babies. So there were many families where hepatitis B, you could trace back 1, 2, 3 generations of people who had hepatitis B. Well, in the late 80s, we came up with 2 great things. One is a vaccine against hepatitis B. And this vaccine against hepatitis B is very effective. Nothing's 100%, but pretty close. And we also came up with something called HBIG, which is hepatitis B immune globulin. That is antibodies gathered from people who had the disease that you would then give to somebody to prevent them from getting the disease. And this HBIG is similar to the monoclonal antibodies that we use, like Regeneron, to help prevent disease. And so they really worked. And then what we recognized was if you had a mom who had hepatitis B, you could prevent the baby from getting hepatitis B by giving the baby, as soon as it was born, a combination of HBIG and the hepatitis B vaccine. What we found was that it went from about a 50% chance of the baby picking up chronic hepatitis B to a 0% chance. And we pretty much stopped that chain of transmission from moms to babies. Starting in the early 90s, we started giving every baby a hepatitis B shot, first one in the hospital, and then at 2 months and 6 months. And I can proudly say that over the last 5 years, I've not seen a single kid infected with hepatitis B. That really is amazing. So I go back to when I started medicine, hepatitis B common, and now haven't seen it in 5 years. So Laura, tell everybody what we do in public health to be sure that nothing falls through the cracks.
Sure. So to prevent perinatal hepatitis B transmission, that's transmission from mom to baby, usually in delivery, we recommend a couple different things. The first is we recommend everybody get their hepatitis B vaccine. We recommend that all women get prenatal care before delivery, and at those prenatal visits that they get tested for a variety of diseases like HIV, syphilis, and hepatitis B. And if positive, patients can work with their doctor and their pediatrician to ensure that at delivery, the baby is given hepatitis B immunoglobulin and their first dose of the hepatitis B vaccine. So public health, we talk to women who test positive for hepatitis B. We recommend testing of household or other close contacts. And we keep in conversation with the woman as the baby passes 2, 4, 6 months until they're completed their hepatitis B vaccine series, and then recommend testing at that point to make sure that the baby has not contracted hepatitis B after that. So we've had very few of these cases since I've been here in Douglas County, because the majority of women who are of childbearing age now, like myself, were vaccinated in the 80s or 90s. And so very rare for someone to test positive. And then we should not have any infants born in Oregon contract hepatitis B, because we have the tools to prevent that from happening. And if babies do contract hepatitis B at delivery, they face an 80 to 90% chance of developing chronic hepatitis B. And if they develop chronic hepatitis B, they usually have a 25% chance of developing liver cancer or cirrhosis later in life. So it's definitely a very worthwhile prevention strategy.
And so this reveals one of the basic tenets of public health. When we do our job correctly, and every baby is prevented from getting hepatitis B, you don't hear about it. And so over the next few weeks, we're going to talk about some things that were common when I started in pediatrics. And in one generation, we've gotten rid of. And I think hepatitis B is a great example of that. And so, kudos to everybody who does this. This is not just public health. These are our obstetricians who are screening the moms. These are our pediatricians who are giving the shots. And these are all of the people involved in the care who are helping to prevent this bad disease. So we'll give one to public health for getting rid of hepatitis B in my lifetime. My goal would be that we have dozens of diseases that we could get rid of in my lifetime. We're not there yet. But there are other things like measles, syphilis. We really do have the possibility of getting rid of those in my career, and I promise to work until we do. So again, I may not retire for another 10 or 20 years, but the goal will be for public health to really eliminate these diseases, which were really scourges before. So Laura, thank you for everything you do. We'll have you back to talk about some of the other diseases that we're a little less successful with, but some of the diseases that we can in public health help to eliminate. Again, this is Dr. Bob Dannenhoffer, the Public Health Officer of Douglas County. Thank you for joining us, and we'll do this again next week.
Thanks, Dr. Bob.